Well, thank you, everyone. I really am enjoying this nice, warm Dallas weather. I know that we're after lunch, so one thing before I start, if everyone could just stretch a little bit, I'd have us do jumping jacks, but if we could just stretch and wake up a little bit, get the air moving. All right, good. All right. I don't want anyone falling asleep on me. Okay. So this is not the title that I picked. It was a title that was given to me. So it helped me to sort of think about ways to talk about personalized medicine. So as we go along, I'm going to be talking sort of from the trenches as a clinical geneticist. And I'm going to give you some examples of how we're actually using some of the technologies that we've heard about today in actual practical medicine. But the expansion of this over time is kind of unimaginable, but I'm going to be giving you very practical guidelines. I'm also going to be telling you about my own personal genetic information, my disclaimer. So I chose to share this with you. Okay. So I have no conflicts of interest to disclose, and these are the primary objectives. So the objectives are to have you guys, after this talk, hopefully, be able to have some practical ideas about how we can actually use these tests for patient and family treatment for at least one disorder, hopefully a few more, and to talk about pharmacogenomic testing and how to tailor treatment for patients, because these are practical things that we're actually using today. And then I have developed some secondary objectives. These ones I threw in. I think that we're going to talk about variants of uncertain significance again, and I'm really glad that Dr. Brower sort of kind of gave you some background on that and other talks. I also want you to be able to ask some questions when you're ordering a genetic test. So just because you can do testing doesn't mean you always should do testing. So before you order one of these tests, we should think about why are we doing it, what's the value to the patient, how much is it going to cost, all of those things are important. And then we're going to talk a little bit about actually looking at the genetics of pathogens. I threw that one in there as well. So I'm hoping that I talk about the beauty of genetic testing and not the terrifying aspects of genetic testing here. Okay. So what is the promise of personalized medicine? How many of you know about some of these not commercial laboratories that are offering genetic testing? Okay, so how many of you have heard of things like 23andMe was mentioned before, but there's others. I don't have any preference. So I want to tell you, I participated in one of these personalized genetic testing, but I didn't pay for it. I did it on a research basis, so it didn't cost me anything. So I gave them some saliva a few years ago, and every once in a while they give me some information, and I'm going to share some of that with you. So what is the promise of personalized medicine? Everybody holds it out. Oh, you know your genome, you're going to know what to do with your life. Well, it may help you make some lifestyle decisions if you know certain things and to improve your health, although most of us know some of the things that we should be doing. But it also can help us as clinicians pick the right medicine, the right dose of medication, maybe avoid some complications of some of the treatments that we give patients, and those are all great benefits. I'll be talking about that a little bit. Can tailor treatment for things such as cancer by looking not at the genetics of the person, but the genetics of the tumor. So I'm going to talk about that for a little bit. And then a little bit about looking at viruses and bacteria. Okay, so there's all kinds of wonderful things about genetics, and there's some scary things about our genetics, right? And so we have to consider all of these things. And you've already heard about SNPs and variations. So there's variations, and then we talk about mutations and polymorphisms. There's a lot of different words that we use. When I think of a mutation, I really think of a known variation that causes that gene not to do its job, and it causes a problem for the person, a really pathogenic mutation. But there's all of these variations that we have within our genetic makeup that might predispose us to a disease, but we may not get the disease, so not fully penetrant. So there's a lot of different variations that we talk about. And you've heard a lot about those, so I don't have to explain it. That's good. Okay, so we talk about the billions of bases we have. So I looked at these numbers, and the numbers that you hear each of us talk about, how many genes we have, it varies a little bit. These are all guesstimates. But we have about 3 billion bases in the human genome. And of those, there's lots of SNPs, or those variations. There's 10 million of those. There's about 19,000 coding genes, or 23,000 genes within our genetic makeup that actually do something that we know about. And then there's lots of these single gene disorders that we can identify, but those are specific mutations within a gene that causes a problem. And then that's all housed on our 46 chromosomes. Okay, so I'm going to talk about some common diseases. And I'm not necessarily talking about pediatrics right now because we're not really using these technologies right now in pediatrics, but it's coming very shortly, if not now. But I want to talk about coronary artery disease because it's something that's very common. We know that it's the leading cause of death in the United States, and we know that men are more affected with this than women. We know that African Americans are 30% more likely to die from cardiovascular disease. Caucasians are much more likely to get coronary artery disease than Hispanics. And there's a lot of risk factors that have nothing to do with genetics. Your smoking, high blood pressure, high cholesterol, diabetes, inactivity, and overweight. So all of those things can contribute to coronary artery disease. So when I gave my saliva to the lab to do their magical genetic testing, they keep sending me this data, and I go, oh, that's nice, but it really doesn't mean much. So this is my result. So it turns out that there is a SNP, a polymorphism, that's associated with an increased risk for heart disease. I thought, okay, so what is my risk? Well, there are some people, the 27% of people have 2 copies of the non-risk variant. Those people down there in purple on the bottom, those are the lucky people that don't have either of the SNPs, so they're probably very unlikely to get heart disease. Then there's me in the middle, along with 50% of the population who has 1. Okay, so what does that mean? And then there's 22% of people there at the top who were unlucky enough to get 2 copies of this variation. So how does this change my risk? And it turns out that it doesn't change my risk a lot. My risk for heart disease is based a little bit on my family history and probably a lot more on my lifestyle issues. So, unfortunately. So because my father, who had a mild heart attack when he was 38 years old, he was a silent heart attack, but he lived to be 82 and had no more heart problems from it. But because there's a positive family history for heart disease, they took my genetic information and they gave me this risk. So my relative risk, based on my genetic information and my family history, is 1.2%. Well, if you're not into statistics, you could scare yourself. Oh no, I'm at increased risk for heart disease. But if I look at that number, I'm like, well, if I had a 10% risk before, now my risk is 12%. Okay, is that enough for me to eat better, exercise a lot, and do all those good things that I need to do to stay healthy? I don't know, 12%, 10%, maybe not. Okay, so the question is, how does knowing these things about ourselves impact our behavior? I don't smoke anymore, okay, so that's good, all right, but I did that before I got my genetic information. I don't exercise enough, although I try. You know, does it really change how we eat? And, you know, and all of the things that are hard, those lifestyle changes. And as physicians or healthcare providers, we encourage our patients to eat healthy and exercise, and hopefully we're good models for them. But it's difficult. It's a hard thing to do. Okay. So we've already heard about next generation sequencing. So the next thing I'm going to talk about is how are we using next generation sequencing in the trenches, like where the rubber meets the road. How am I using it today? We've already heard some definitions, you know, about how next-gen sequencing is done. But then when I think about it as a clinician, how do I actually use this information in practice? So there are times, rarely, that I might do whole genome or whole exome sequencing, but I have to know why I'm doing it and what I'm going to do with that information, okay? And sometimes, rather than having all the information, I may focus in a little more on a panel, and that's actually where I think we're using it a lot more today clinically. When we have a finite set of genes that we're looking for because of a patient's phenotype, because of what's going on with the patient, okay? So I swear I did not see Dr. Brower's slide, but here, and I made up these colors myself. I thought of it like a stoplight, okay. So when I get a genetic test result back, when I do some next generation sequencing, I'm going to get these kinds of things. Well, benign means that we've seen it before, it doesn't cause any problems, it doesn't change anything in the gene function. The thing that makes me crazy, and the thing that I deal with every day, is these variants of unknown significance, these VUSs. They absolutely make me nuts. If we know something causes a disease and is pathogenic, that's great. It's easy. We know it's a bad mutation. It's going to cause a problem. But this VUS makes me nuts, okay? So I'm going to give you a practical example. I'm going to tell you about a patient. It was a kind of a tragic case that we dealt with, but we got some information from it. The specifics of the case are not relevant. What the disease that this person had isn't really relevant. It's the process that we went through to come up with some answers. Okay. So this is the clinical scenario, but it could be any disorder that we're talking about. This was a young man, well, he's young compared to me, a young man that came in with altered mental status to the hospital, and it turned out his ammonia level was very, very high. And he didn't have liver failure. So most adult medicine people who see somebody with a high ammonia assume, oh, it's because their liver's not working, they're an alcoholic, or they have fatty liver or something, what's going on? But he didn't have liver failure. And unfortunately, he got very sick very fast, and then he went into a coma. He was transferred to our hospital, and he passed away. So this is tragic, and it's tragic for this family. And the question is, what happened? Why did this happen? And is there anybody else in the family that needs to know about this? Because there may be something going on that could actually affect other people in the family. Somebody, not me, my partner, saw this patient in the hospital before he passed away and said, we need to do some metabolic studies. So they did some metabolic studies, and he had an elevation in orotic acid, and he had a very low citrulline, which is something that most people wouldn't know what that means. But what it means is that he likely had a condition, a urea cycle defect, ornithine transcarbamylase deficiency. Like I said, the clinical scenario isn't important, but it's a rare metabolic disorder, and it primarily affects boys because it's an X-linked gene. Okay, so there may be some reason for this family to know about this. So what we did is we sent some DNA from him to our lab who did next-generation sequencing, but we specifically looked at the OTC gene, which makes sense. So I'm not going to get confused about all these other variants. Okay, so this is what my lab sent me, and I wasn't really happy. Okay, so what they found on this variant is they actually found 7 different variations in his one OTC gene. So there were 7 changes, okay? So 6 of them were not, so I'm having, okay. Well, 6 of them at the bottom, there were 3 likely benign and 3 benign gene variants. Okay, so I'm gonna dismiss those. Those I'm not even gonna think about. What makes me crazy is the variant of uncertain significance, right? So what they told me from our lab is that what they found at this one point is that a T was replaced by a C. The base thymosin was a cytosine. And what that meant is that there was a change in the amino acid sequence. A serine was replaced with a proline. And they looked at the ClinVar database. Remember, we heard about that? We can go there and see if somebody else has this problem. And based on all of that, my lab, my own lab in my own hospital, is telling me that it's a VUS. It's probably not significant. But here's a person that died, and I think it might be significant. Okay, so what do you do when you're in trouble? So this is what I do. First of all, I take a deep breath and I try not to panic, right? I have a family who's devastated. They lost somebody. They need an answer. And then I go to the databases myself. And this is, as a clinician, it's a little harder for me, but I go in the databases and I look. I did a literature search. I looked about different species, and we try to find out how does it change the structure of the protein? Is it a problem? And then I phone a friend. It's like Who Wants to Be a Millionaire? You can phone a friend. So I phone a friend. So what I did, actually, is I sent out a panicked email to everyone who does adult onset urea cycle defects in the country. I don't know all of these people. I know a few of them. But I sent out a message, please help me. Can you look at this case and tell me what you think? And you'll be happy to know that somebody here in Texas came to my rescue. So this is Dr. Zhang at Baylor, who I've never met. Nobody? Okay, whoever's from Baylor, thank you, Dr. Zhang. Dr. Zhang sent me this little message back. Okay, so I think this is I think it's a pathogenic variant, but I want somebody who knows what they're doing to tell me that. So he tells me that the mutation has never been found in 40,000 controls that they've looked at for urea cycle defects. That's helpful, but a lot of the mutations that we see are individual mutations or private mutations. But what he told me that was more helpful is that this serine at position 81 is highly conserved across species. So yeast and Drosophila and all of us have a serine there. So it must be an important amino acid. So changing that to a proline is a problem. And then he did something really neat. He gave me these two little pictures. So the picture on the left is the normal protein folding. He gave me I don't know how he did this, but he gave me this beautiful three-dimensional picture of what the normal OTC protein looks like. And he said that when you substitute a proline over there on the right, you see the proline over there, it creates, and I'm using his word, a tiny clash, a little tiny clash there with an adjacent residue. So he's looking at this saying, I think this really is pathogenic. And you know what? I believe him, and I'm really glad that he gave me that information because I feel that this information then is helpful for the family. And how does this help the family? If this young man's mother is a carrier for the mutation, she may have it within her genetic makeup. Because she's a woman, she doesn't have the disease. His brothers or nephews or uncles may be at risk for also having this condition. So this is very helpful. But this is a lot of work for one condition, and you have to know what condition you're looking for. So before ordering one of these complex genetic tests, there's a bunch of questions I always ask myself. Lots of clinicians send patients in to see me because they think they have this condition, this genetic condition, or they have made that diagnosis, and they go, oh, go see Dr. Pletcher. She'll do your gene test. Well, it's very nice, Dr. Pletcher will do your gene test, except that it's not that easy to do. It's not something that you can order through LabCorp or Quest. It's something that you have to really want to do. So the first question I ask is, which genes for this condition do I think are appropriate? There may be a panel of genes. How will uncovering a specific diagnosis help the patient? So how is it going to benefit that patient? And so then if I decide, yeah, it's really going to help the patient potentially if I know that they have this versus this condition, then how do I convince the insurance company that that's the thing to do? And then I also ask myself, am I more likely to come up with an uncertain answer that makes me crazy and makes the patient uncertain, or am I more likely to come up with an answer? So we need to think of all those things before we order the test. So I'll give you an example of something that we actually are using in pediatrics that is somewhat helpful. I think people have talked about panels before. A group of genes, instead of doing the whole genome, but a group of genes that we're looking at specifically because of the clinical phenotype. So we see a lot of children that have intractable or early onset epilepsy. We're not talking about somebody who has epilepsy that occurs at sort of a typical onset of, like later childhood and is well controlled, but really severe epilepsy. And there are epilepsy panels, and if we can pinpoint a specific gene that's causing the problems, we actually may be able to find some treatment. There are syndromes that are associated with epilepsy that we might uncover if we're looking at those specific conditions. Some of them clinically, us geneticists may actually be able to figure that out by doing a good exam, and sometimes not. It depends on the age of the onset, too, of some of the features of those conditions. But there are also some non-syndromic forms of epilepsy, and knowing the specific gene may be quite helpful. So some of the laboratories are now offering these. These are not the big commercial laboratories, but some subspecialty laboratories. Some offer a gene. I looked at different numbers of genes that they're offering. Some offer a 30-gene panel. Some offer 145 genes, and there's those in between. But the thing about this, and this is where we come up with the issue of the copy number variant versus the next-gen sequencing. Before I ever order next-generation sequencing, or before I order a gene panel, I always want to do probably a microarray first. It's more readily available. We can do it. Actually, I don't have any problems with our insurance in our state. I can do it on CGH test and look for a copy number variant, a small missing or extra bit of genetic material. If it's negative, then we can proceed with the next-gen sequencing. But we would not do that in the case, we wouldn't jump just to the next-gen sequencing without doing that for most cases, for most conditions, I think. So I found this paper. I thought it was really interesting. In 2013, they presented sequencing of patients, 1,600 individuals with seizure disorder. And this group looked at 53 genes that are known to be associated with epilepsy. And of those patients, 16% had a recognized pathogenic mutation, but I also want you to see that 30% had one of those VUSs that may or may not be significant. And they felt that of those 53 genes, 9 genes were identified that had a high frequency of intellectual disabilities. So those are kids with seizures and intellectual disabilities. And if you looked at the different categories of seizures, about 21% of those that had a positive test were infantile epilepsies. So it's the highest pickup rate if you have early onset epilepsy as your criteria for testing. Children that had a little bit later onset epilepsy or progressive myoclonic epilepsy had about half as likely chance of finding a mutation. And then we talk about, well, so now you have a gene mutation, what does it mean? And the answer is that about 9 of those genes actually were felt to confer some benefit. So knowing what particular gene was involved with the epilepsy actually changed management. And that's really where I like to focus our attention. So I'll just give you some examples. So the examples of actionable genes amongst the epilepsy genes that they tested for, we know that POLD mutations, those children are at high risk for liver disease or liver complications, so you should avoid valproic acid. Okay, so we know if you have that mutation, use other drugs other than valproic acid. The second line there, those are mutations associated with creatine deficiency, so oral creatine would be the treatment of choice for those children with those mutations. There's one mutation in the SLC2A1 gene that's associated with great response to a ketogenic diet, which is tough to do, but if the kid's going to respond, that's something to know about. It would be a great thing to know if a child had that. There's also some seizures that are associated with B6 responsiveness or folinic acid, so you can give B6 to those patients if they have a mutation in that particular gene. And then there's also some genes that we know that specific anti-epileptic drugs are not indicated for those or should be avoided. So those are all the reasons why doing an epilepsy panel makes sense for early onset epilepsy. So there's many other panels that are out there. I know that we've heard about hearing loss panels and something that Dr. Powell's interested in, but there's also intellectual disabilities or autism panels, and that's after they've had a normal microarray. We might consider doing that. Cardiomyopathy panels for people with dilated or hypertrophic cardiomyopathy, but also other things. I see patients, a lot of the ophthalmologists send patients to me with retinitis pigmentosa or macular degeneration. There actually may be panels where we can do gene testing for those. And so there's a number of panels already available, but how we utilize those and how the insurance company perceives the value of those is a little different. So we have to look at the cost-benefit ratio and whether these are actionable. So now I'm going to talk a little bit about actually using this information from our own genetic makeup to make decisions about which drugs or what doses of drugs to use. And so one of the typical diseases that we deal with in adult medicine is type 2 diabetes, right? Lots of people have type 2 diabetes. Sulfonylureas are the #1 medication used before we resort to insulin. And the way this medication works is it stimulates the pancreas to make more insulin to overcome the insulin resistance in these patients. So what we found is, as we're doing some different genetic testing, is that there are certain genetic variations that may give us an insight into how well you're going to respond to this medication. So there may be patients that are already on insulin, but if they have certain genetic variations, we may be able to actually wean them off insulin and put them back on the oral medication, which would be a benefit to the patient. There are other variations that say this patient is not going to respond to the oral medication, so you might as well go right to insulin. You're going to be wasting your time using the medications. And then there may be other polymorphisms that can predict that a patient may be at increased risk for hypoglycemia or bad response. We may need to use a lower dose of the medication or switch to a different medication for those patients. So we're not using this genetic testing right now, I don't think, for our type 2 diabetics, but I think it probably will be something we'll be using soon. So here's another example of when picking the right medication for a patient can depend on our genetic makeup. So we know that rheumatoid arthritis is an autoimmune form of arthritis. It's very severe. The treatments are immunosuppressive agents, and immunosuppressive agents have a lot of side effects. And so we want to make sure that we're doing the right thing for the patient. So we have to really look at how we use these medications, and usually we do it by trial and error. So if you're a rheumatologist, you may try this medication, and then if that doesn't work, we try another one. Well, it turns out that there are certain genetic polymorphisms or variations that might tell us which patients are likely to respond to this particular medication, methotrexate. If a patient has a favorable polymorphism, we know that they may respond to methotrexate, which is one of the good medications for this. And there are other patients that may not respond, and we might know that based on the genetic information, we would not even give them methotrexate. We'd actually select a different medication potentially to treat them. So now another example, the right dose. So tamoxifen, I'm sure a lot of you have heard about tamoxifen. It's used to treat women who've already had breast cancer to block the estrogen receptors and hopefully prevent recurrence of the disease. Tamoxifen is metabolized by a certain enzyme, and it then converts the tamoxifen into the active ingredient, the endoxifen, okay? Women with different variations within this gene, it doesn't mean the gene doesn't work. It means that the gene works well, not so well, or really well. So there's a gradation from poor to ultra-rapid metabolizers. So how your body metabolizes drugs will depend upon which variations you have within this gene. So it turned out one of the reasons they found out about this is poor metabolizers have a very poor response to tamoxifen and actually have a very high rate of recurrence of breast cancer. So someone who's a poor metabolizer, if you knew that up front, you might give them a higher than usual dose in order to get the effect from it. Conversely, if you have patients who are ultra-rapid metabolizers who are really converting this drug very rapidly, they may be able to be on a much lower dose of tamoxifen and still benefit from it. So it's something that we can consider in our treatment of patients and trying to negate side effects and then to improve outcomes. Okay. And another, this is the final one, I think, in avoiding side effects. So we talk about medications and what are the side effects from the medications. If we can predict in advance who's at high risk for a side effect, we may be able to help the patient. So a lot of the atypical antipsychotics that we're using, we like them because they have fewer side effects in general, fewer complications than the old-fashioned antipsychotic medications. But that's not to say they don't have some side effects. And it turns out that some of the atypical antipsychotics for patients may put them at increased risk for OCD or obsessive compulsive disorder. And it turns out that there's certain genetic variations that might predict or infer that kind of a possible side effect. So if you were able to do genetic testing for these two specific genes in advance of putting a patient on something like Abilify, you actually may be able to avoid having a problem. You may choose a different medication. So doing genotyping before you start a person on this medication rather than waiting for the side effects to occur might be something that you could consider doing. Okay. Now, I know you saw something about cancer before, and this is a similar kind of slide. But when we think about cancer, what we know is that most of us that develop cancer don't have it because we were born with a cancer predisposition. So although there are some people who inherit cancer genes, most of us don't have it as a result of an inherited mutation. But on a cellular level, cancer is genetic. Every cancer is genetic, and there are genetic changes and mutations and things that occur within the cells. So over time, as we see normal cells going through some small genetic changes that make the cells grow a little faster, then more mutations occur, and over time, as we progress from left to right, we start to see, I'm gonna try this again. There it is, okay. As we progress from left to right, we see that over time, as more mutations and genetic problems occur within the cells are growing more rapidly, then we start to see malignancy occurring. And finally, in the end, you might have an invasive cancer that metastasizes. And so these genetic changes are occurring across the continuum. So the question is, when we look at tumor cells in two patients who have the exact same phenotype, they have, let's say, colon cancer, and it's exactly the same size and the same stage, can we differentiate which patient's going to respond to which drug? Even though the tumors look exactly alike on a histologic basis and on a staging basis, can we predict? So instead of looking at the genetics of the person, we're looking at the genetics of the tumor, okay? So sometimes we can actually use genes or gene profiles of the tumor itself to decide which treatments are best for that patient. Okay? So in this case, there are, for people with non-small cell lung cancer, there may be specific mutations that might predict which person should get which drug. So mutations in EGFR have been seen in more than 20% of patients, and these particular gene mutations are associated with good sensitivity or good response to tyrosine kinase inhibitors. So patients that have those mutations, that's probably your first line of treatment that you're going to want to use on their tumor that has that mutation. There are also other mutations in different genes, and these patients tend to be younger. They tend to be female non-smokers, and they respond instead to a different medication, a different chemotherapeutic agent. So if we knew that they had mutations in that gene, we would then selectively go with that medication to treat the cancer. And then conversely, there are patients who do not respond to the tyrosine kinase inhibitors, and we might be able to actually predict which patients those are. They have mutations in KRAS. So these are all different mutations within the tumor itself that might help us to decide which chemotherapy to use. There has been something that's been available for some time in screening for breast cancer. And it's usually for women who have a small tumor that has not metastasized, the lymph nodes are negative, and the women on the outset look exactly alike. They have a small breast cancer, it hasn't spread, and can we predict which of those women are going to be really great responders to medication or may not need chemo at all, and which one might just benefit from lumpectomy, and which ones actually need chemo. So they've been screening different genes, and they've identified 21 genes for some of these tests where we can actually look at what is their response, and can we predict who's a low risk for recurrence and a high risk for recurrence based on what the tumor looks like on genetic testing. And so the patients are actually given these ratings of low risk, intermediate, or high risk. And so the treatment for these patients that all actually look alike on the outset would be very different. And so some women who are low risk might avoid surgery or chemotherapy or radiation therapy. Those that are high risk, even though they look at the outset to be okay, may actually benefit from a more aggressive treatment regimen. So that's why I think looking at the tumor-specific treatment is going to be very helpful as we start to identify which mutations and genes are associated with responses. Okay. Now I'm going back to talk about chemotherapy, but in this case, I'm talking about the patient's DNA. We're going back to the patient's DNA. We're not looking at the tumor itself. So when we're looking at, in this case, the TKI, the tyrosine kinase inhibitor, there are some patients who have longer progression-free survival in response to TKIs, but you have to look at the genes of the person themselves in terms of their metabolism and how they respond to that. Okay. Conversely, there are patients with metastatic colon cancer who have specific mutations in the VEGF gene, which has to do with vascular invasion. And those patients that have specific polymorphisms within their own genetic makeup that they were born with respond very well to this angiogenesis inhibitor. And patients who don't have that may not respond to that, so you wouldn't use that agent for them. And I'm sure that over time there's going to be many more examples of when these medications or when the treatment regimens for patients are going to be different. Today, for most of our patients with cancer, there are certain regimens that are routine. If you have this and you have this stage, this is what we're going to do. Now we're going to fine-tune that and be able to actually do personalized chemotherapy, radiation, or cancer treatment. And then to avoid some complications. So there are some patients who have polymorphisms in a gene that are at high risk for developing hypertension in response to certain medications. Sometimes patients may be at higher risk for developing some painful side effects. So if you know that in advance, you would not choose that agent to use for that patient. So these are ways that we can, avoid some of the complications. And chemotherapy has a lot of complications and side effects as well as other medications. Okay. So this is my last little part. I'm going to be talking about bacteria and viruses. So now we're looking at genetics of the person. We're looking at genetics of their tumor. In this case, we're looking at the genetics of their invaders, the mycobacterium. So this is TB, and we know that one of the big health issues today in tuberculosis is the multi-resistant drug TB. Okay, so these are tuberculosis bacteria, mycobacterium, and then we look at different ways of looking at the bacterium. Right now, the way that we identify drug resistance is we grow the mycobacterium, which are very slow growing in culture, very slow. And we look at how they respond to different medications. But it turns out that we can actually look at the DNA of the bacterium. And if we find this RPOB gene mutation, we know that it's a gene that suggests that they're resistant to the drug rifampin. So this little gene allows the mycobacterium to change its diet. And by changing its diet, it's able to survive when rifampin is given to treat it. So this could actually be a quick way of identifying those mycobacterium that are not going to respond to rifampin. Then you have to use other drugs and use multiple other drugs to treat. And finally, hepatitis C. With hepatitis C, I'm seeing all these ads on TV now. I don't know, I'm not an infectious disease person, but I see all these great ads on TV. They actually have some drugs now that we're using to treat hepatitis C. But we know that hepatitis C virus, as with a lot of other viruses, has a way of changing its genetics. And we know that hepatitis C is a life-threatening condition. It leads to liver failure for a lot of our patients. And we haven't had until recently treatment. But now these new antiviral drugs are coming on the market, and we may be able to identify which hepatitis C genetic changes might make them susceptible. And we may be able to look at some mutations within the virus itself that confers sensitivity or resistance to these agents and be able to handpick which medication to use to treat and hopefully cure hepatitis C. So this is something that's very exciting and sort of right on the verge of being used clinically. Okay. So as we look to the future, I think we need to start to think about how we can use this information in a sensible way to understand our own genetic variations. The information that I've gotten back from my genetic is not very helpful. I do know that I'm a rapid metabolizer for Coumadin. So if I ever have to be anticoagulated, they have to give me a higher dose of Coumadin. That's the only good thing I've learned, really, that's been very helpful for my genetic information. But someday we may be able to use this in a more sensible way and actually make it practical. We know now that oncologists may be able to look at tumors and to also look at their patients to decide what treatments to use. And I think it's going to move outside of oncology, and it's going to be for other medications and for other conditions. We may wish to find out earlier in life what genetic predispositions we have for some of the common things like heart disease, diabetes, or hypertension. I don't know if I want to know if I'm at risk for early onset Alzheimer's because there's no treatment for it. So if that test was out there, I'm not sure I'd want to know that information. But these are things that we can decide as individuals what information we want. Just because it's some information that I don't want, there may be someone else who wants to have that information. And so we have to go through the whole process of getting the informed consent. And people really need to understand, is this information that I want to know, is it going to be helpful to me? Is it going to make me nervous and upset and ruin my life? So you don't want information that's not going to be helpful to you. Okay? So these technologies have power to impact our treatment decisions if they're used in a sensible way. But I think we need to do targeted testing. I don't think we need to do shotgun testing for our patients. And so I don't think we're quite ready to be doing genomic testing on all of us or even on all our newborns. Once we begin to understand how these different mutations are impacting patients, and we see a decrease in the cost of the testing, number one, so it's not going to cost us $1,000. Amy, what was the, you can do it, how much does it cost to do it? What was it? $1,000. I know it costs $1,000 now, but yeah, but now someday they're going to say, but this much is, I don't know, a tube of toothpaste. It costs as much as a tube of toothpaste. You can do your genetic testing. But the cost of the testing is only one part of it. The other part's interpretation. So we want a rapid turnaround time so it's useful information. If we're going to use it to decide what drug you're going to go on, We can't wait weeks and months for a test result to come back. We want to have it in real time so the patient can benefit from that. If I'm going to anticoagulate somebody, I can't wait 3 weeks because they're going to die from a pulmonary embolism before I get around to deciding what dose of drug to give them. We have to figure out who's a candidate for the technologies, which selected patients could really benefit from it, and we need to really understand the significance of all these variations, and that's where some of these databases will be very robust and growing over time. Okay, so this was my daughter and our nanny and I. We went on a trip to Colorado to see what we spend our time doing. But thank you for your attention, and I will answer any questions you have.
Okay, so back to the American Academy of Pediatrics recommendation. So I have a lab that is willing to do the chromosome microarray for $89. So I have the opportunity for a lot of my patients who have developmental delay, autism and things like that, to get this test. So the cost is not my problem. My problem is I do the test. I understand the Fragile X. To me, that's really logical. I get that. But I don't know what I'm looking for when I order the CMA. What am I going to tell people? And do I do further testing, like the genome, after I get the CMA back and it's negative?
Okay, so those are great questions. Okay, so this is my philosophy on any test you order. If you order a test and it's a test you really don't know what it means, you probably shouldn't be ordering the test because it's going to come back and you're going to panic and you go, oh no, what does this mean? I got something abnormal. Now, in terms of microarray being used for children with autism and developmental disabilities, I think the recommendations are pretty clear that, at least as a first tier, we would do chromosomes, a microarray, and Fragile X for kids with autism or developmental disabilities. The problem with microarray is that about 1 in 20 patients of mine, this is just my number, but I do a lot of them. So 1 in 20 patients will have a variation that we don't know what it means, and I have to do the parents. And then if the parents have the same variation, it's a little harder to interpret, but it might be a normal variation that's been passed down through the generation. So it's less likely to be causing the autism or the developmental delay. There's some very well-defined copy number variants that we find in microarray that definitely are associated with increased risk for autism and intellectual disabilities. In terms of whole exome sequencing, I have not done that or offered that to patients with just intellectual disabilities. I've done a few whole exome sequences. Every one I've done, I've come back with a positive result, but I've been very selective as to who I use. And these are patients that have very clear evidence of a single gene disorder. They may be dysmorphic, they may have multiple anomalies, severe intellectual disabilities, a sort of a whole gestalt of it. This person has a genetic disorder and I cannot figure it out. And I've done a microarray and it's negative. And I know that they have something, a single gene disorder. And I have been able to find an answer. But I think for intellectual disabilities, at least for me, I feel very uncomfortable because I'm much more likely to have all these variants that I'm not sure about. So I don't move beyond the microarray for patients with intellectual disabilities or autism if they don't have any other physical findings or birth defects.
So I have another question.
Oh.
I have 2 more. So if anyone doesn't have a question. So I have a patient whose grandmother was diagnosed with leukemia, and she had a 13p deletion. And now
the grandmother?
Yeah, the grandmother was diagnosed with leukemia, and her doctor told the mom that she had a 13p deletion.
In the tumor?
I mean, Q. 13p
But she had a deletion in the tumor or in her body?
Well, it must be her body because the mom came back and said all the family's supposed to be tested.
Okay, all right.
And so then the son, who has lots of, my patient, has quite a few interesting problems, and they don't seem to be related. One's a kidney hydronephrosis, one is a Coates disease. And so will the chromosomal microarray test for that 13q deletion.
Okay, so, so the problems that he has may or may not be related, depends what genes are in that segment, but the microarray would let you know that. So the microarray is really good at picking up small missing or extra bits of genetic material. So based on his grandmother, his risk of having that deletion is 25%. What, 50, like half and half, right? 25% that he has a deletion. He may have it, but it may not have anything to do with his other problems.
Correct.
But the microarray would give you that information, whether he has a deletion. There may be an oncogene or a tumor suppressor gene or something that's in that region that may have predisposed the grandmother to her leukemia, or it may be unrelated. So I'd have to look at the genes in that region to kind of characterize whether that's relevant or not. I'm assuming if the doctor thinks the family should be tested, but maybe or maybe not, it's not necessarily relevant. The grandmother, though, is intellectually fine. She has no other health issues,
Correct.
just leukemia. Okay.
Correct.
I think it's probably unrelated, is my guess, but I have to know the genes in there. Okay.
All right,
I
last
need one
question. I have a alternative treatment doctor who sees quite a few of my kids, and then they come to see me with their tests. And
Are they metabolic tests by any chance?
yes, there's a lot of metabolic.
Okay, all right, no, sorry.
Yes. And then there's the MTHFR gene.
Oh,
And they say that you can't get vaccinated if you, with measles-mumps rubella, because he has a high homocysteine, one of the kids at level, because and his MTHR was low.
okay.
Okay.
Okay, so, yeah, so MTHFR, okay. So I actually did my MTHFR. You know, geneticists, we can't help it. We have a lab. We just like testing ourselves. So I'm a carrier of one copy of the MTHFR mutation. It turns out that 1 in 3 of us are carriers, so I'm not so unusual, which means 1 in 9 of us has 2 copies of the MTHFR gene. So if you have this genetic variation on 2 of your genes, then you have an increased risk for elevated homocysteine. And elevated homocysteine long-term in your life may be associated with increased risk for cardiovascular disease. It has nothing to do with immunizations. But if you have that, if I happen to have 2 copies of that gene, I would be taking a vitamin supplement every day. I would be taking a B complex vitamin, B12, B6, and folic acid, and I would be fine. And my homocysteine level would probably be fine, and I could have all my immunizations. So I don't know where, but a lot of people are coming to me with this MTHFR saying, oh my God, I have this. Well, yeah, like 1 in 3 of us have 1 copy, and 1 in 9 people have 2, and most of us are not affected by it. So, yeah, so I would just give them like a B complex vitamin, but there's no relationship between elevated homocysteine and any problems with vaccines. Is this person just not like in favor of vaccines, the alternative doctor? I'm sorry, except for MMR? MMR? Okay, I'm not sure. I'd like to see some data that would suggest that MMR shouldn't be given to somebody with an elevated homocysteine level. But yeah, I'm not sure. Vaccines are good. Okay.